available. But I'd like to introduce Michael Werner. Michael is a urologist in Westchester County. Bradley Adler was kind enough to introduce us to Michael. And Michael's going to talk about testosterone replacement therapy and ED in a primary care practice, because there appears to be a lot of interest in that area. And Bradley thought that Michael would be a great resource. So Michael, I'm going to turn it over to you. Michael's going to talk for a few minutes, but then he thought the best approach might be just Q&A. So Michael, it's all yours.
Got it. So my background is I'm a urologist, and then I did a fellowship in male infertility and male and female sexual dysfunction. And then I opened up my practice only doing those, which is sort of unusual. In fact, when I was at White Plains Hospital for my, when I was applying for privileges, they said, well, of course we will accept you, but you're never going to make a living because it's just too specialized. And I was like, okay, I won't make a living, but this is what I want to do. But it has worked out fine. In these areas, people sort of can seek you out. When I finished my fellowship, I was literally the only person in, I don't know how many miles doing male infertility. And so people come in and say, you got your name from 3 different places. And it's like, well, that's very easy because I'm the only person doing this. So, when there's no competition, it's easy to be good. So, so the 2 topics that I'll talk about, but we can break them up because they really are, I think, very fascinating, and their important topics are testosterone replacement therapy and, the treatment of erectile dysfunction. So I'll start with the testosterone replacement therapy. So I will say I am a cheerleader. I'm a big advocate of testosterone replacement therapy. And I think it is one of the areas where we are massively under treating, both in terms of who we're treating and how we're treating them. And I think it is one of the things that when we treat can make a dramatic difference in the quality and probably quantity of people's lives. And it is very poorly done in general outside the expert circles. So I don't pretend to be the only person, but it's one of those areas where the more familiar with it you are, the more comfortable. Like the lipidologists are much more adamant about bringing, lipids down than the average, internist or GP. The more you know, the more aggressive you are. Or the average urologic oncologist who has integrity will do less biopsies because they know when they can pass on those. So I think testosterone really is undermanaged. So the definition of a low testosterone, again, by number and by the Endocrine Society, is lower than 300 nanograms per deciliter. And the Endocrine Society wants it measured before 10 o'clock. The issue is that once you turn 45, which I found out on my 45th birthday, just coincidentally, there is really no diurnal variation. So it's slightly absurd that we need to do that. And it's hard to get patients at that time. But you will find if you end up treating yourself and you want to get approval for medications, that the insurance companies will hide behind that on a very regular basis. That is the formal definition. And it does not take into account what's actually available. So there are many ways of describing what's available: bioavailable testosterone, free androgen index. The bottom line is that the only other measurement that really matters is your total testosterone and your serum hormone binding globulin, because that's the main protein that binds the testosterone. And if you have a very high serum hormone binding globulin, which some men do, for example, have a very high SHBG, then what gets out of the bloodstream and into the cells can be very low despite having a normal or low normal number. So you really haven't evaluated them until you do some measurement of what's actually available. So that the formal definition is the total being 300 or less on 2 different measurements. So it's very easy if you get someone who meets those, and a lot of men do meet those requirements to justify treating. I will treat men who have a lowish testosterone and a high SHBG, and I will treat men actually who have a low normal testosterone and free androgen index. The key is somewhat the numbers, but also the symptoms. When I started my practice, a lot of the men would come in who were azoospermic and had Klinefelter syndrome. And so they would have a very low testosterone. Many of them were in their 20s or 30s, but many of them didn't have any symptoms at all of a low testosterone. So in my mind, if a man walks in and has a testosterone of 170, but does not have symptoms, they don't necessarily need treatment. I mean, I would look to see if they are having difficulty taking off fat and putting on muscle. I would look for osteoporosis, but then I can just watch them until they're symptomatic. And then conversely, if they have 330 and they're really very symptomatic, then I think we're really not doing them a service by not treating, because it's life-changing. So that's sort of the overview of the definition. Modalities of, well, let's talk about what we aim for. So that is a very controversial, not in my field, but I'm always at odds with the internists, and particularly, is anyone an endocrinologist? Because I don't want to slam endocrinologists, but their knowledge of testosterone is literally puts us at odds all the time. One of my favorite nieces finished her fellowship at Cornell recently in endocrine, and the whole time I was whispering, in her ear, Rebecca, testosterone, nothing. They learned literally nothing, and periodically I get calls, because the guys want her to be more aggressive with their levels that she's comfortable with, because they're just not taught anything. So they're great at thyroid and diabetes, but they're very, very, I would say, parsimonious with the testosterone. When I am treating the men, I am really, if I'm aiming for a number, I am aiming for 600 to 800 of a total testosterone, and even higher if they have a high SHBG. And then what I'm doing is I sort of have them sign a contract, not actually, but a verbal contract, that they're not going to give it up unless they've been on it for a year, because it can take 3 to 4 months to see an increase in energy. It can take 6 months to notice any change in erections, and it can take 9 months to notice a change in libido. And the erection issues, if someone comes in with a lowish testosterone, no other symptoms except for erection issues, then I don't think they need testosterone. We just treat the erection issues. It's really the other symptoms. So I'm sort of marching all over the place. But so what are the symptoms that we're really looking for? So the classic symptoms in my mind are decreased energy, especially if you get a younger guy who is exhausted at 2 p.m., that mid-afternoon nap, they just can't keep their head up, and they're not a shift worker like a policeman or a fireman. They have low testosterone until proven otherwise. And it's remarkable how those naps disappear. So decreased energy, libido is a big one. So if you get a younger guy who is still really attracted to their partner and then just has historically a good libido and is losing their interest, that is, also very good sign that they're the low testosterone. And, and if you give them testosterone, libidos can dramatically improve. Erections, modestly. The first thing you'll see sometimes is when you give men testosterone, they will regain their morning erections. In fact, when they first come in after that first month, sometimes they'll have no change in their symptoms at all. And then I'll go through my 4 E's, which I call them. And the one thing that they'll notice is that their morning erections are better. The 4 E's, just because I do that when I'm doing the history, I sort of made that up and it just worked, are energy level, erections, exercise, and I'm missing one. But those are the things that I'm really looking for. So ejaculation, I guess, because that's how often are they having sex. So those are the symptoms that I'm really trying to treat, and we can make dramatic differences in them. Then if by a year they are not noticing any real improvement, then I will say to them, then we should try you off of it and see how you do, because sometimes they've adjusted to the new normal and about 80% of them come back or 90% of them come back. The changes are not subtle. We are not looking for modest changes. We are looking for dramatic changes in terms of these symptoms, and they do feel dramatically better. And I really do end up, I would say, rescuing a lot of patients who I think have been massively undertreated and are just not feeling well. So what are the treatment modalities? The list is very long now and very complicated of ways of treating testosterone. Going from least invasive to most invasive, and historically, the first thing that made testosterone replacement therapy, or low T, sort of on the map were the gels. There was originally two gels, Androgel and Testum, and they are bioidentical, which in my mind is an advantage. Historically, that's what I would start everyone on, but I find about 80% of the men come off of those because they can't stand doing it every night. It's goopy, it's smelly. They can't touch their partners. If they have young children, they don't want them. Sometimes they get it on their dog and the dog has a problem. So, it's, I find that my success rate is not very high. And also, they're quite expensive. So unless you meet those criteria, you're going to find that the insurance companies are going to kick back. So I use them occasionally, but they're not, they don't stick that often. I'll run through them quickly because I don't want to waste time on the ones that no one likes. There is a patch called Andro Derm. Great idea. When we treat the women with bioidentical hormones, we use patches all the time. Women love patches. Men hate patches. And these patches, because they have to get a very high level, are very irritating to the skin, and no one tolerates them. So I give them out, and I'm not give them out. I write the prescriptions, and I think no one at this point on the patches. I had one patient who said, I feel like I'm a giraffe, because they were getting patches like all over their body that took a long time to go away. So those are very nice ideas, but they just don't seem to work well. There is a new one that I like in very interesting situations called Natesto, and that is put in your nose like a spray 3 times a day, which is very unappealing to most people. And it feels a little bit like you've just put mucus in your nose and you're not supposed to blow for an hour. So it has not proven to be terribly popular. The fascinating thing about the Natesto is it gets you levels that sort of spike and then go down, spike and then go down. And interestingly, it does not suppress sperm production completely like exogenous testosterone does. So that's very interesting for my men who are miserable but want to try to conceive. And so I've been using the Natesto for them. No other man wants to use it, and they can't wait to come off of it once they have conceived. Then we get into the injectables. So there is something called Xiosted, which is a pre-measured injectable of testosterone enanthate. The FDA is very conservative on anything it approves, and so the drug companies have to be very careful never to get levels that are outside what they're comfortable with. So I find that they're sort of underdosing. So the Xiosted is great for the guys who want the injections but are afraid of giving it to themselves because it's what preloaded. It's just that it's very hard to get the approval, and we don't have any flexibility because there's only 2 doses. There is a long act. I'm giving you just more information than you need, but just so you, in case you come across these, there's something called Avid, which is a very interesting idea, which is an intramuscular injection of testosterone given every 10 weeks. Doesn't get great levels, but is a very nice compromise between self-injections and the testosterone pellets. Getting to the chase, the 2 most, and there's also Jatenzo, which is an oral medication, which is fascinating. So we can never give testosterone orally because of the first pass effect on the liver. You would get these high levels and you would get an increased incidence of hepatomas. So the issue was, how do you get it not to get absorbed in the stomach, but get it absorbed in the small intestine and get it into the lymphatics? So they created a capsule that does not get absorbed in the stomach, and actually gets absorbed into the lymphatics in the small intestine, and gets you low normal levels. The disadvantage is, again, getting approval, but also can you get good levels, and you do have to take it twice a day with a little bit of food. And now everyone's doing intermittent fasting and they forget, and as you know, the compliance with BID medications is not great. So most of my patients end up on one of two options. One are testosterone Sipinate self-injections, which they do once a week. Sometimes people split it to twice a week. The interesting thing about the Sipinate is that it can be absorbed. I didn't learn this until about 10 years ago. We think of them as having to be done intramuscularly, but it does not have to be intramuscular. You can do it subcutaneously. So it's very easy to teach, and you don't have to worry about them doing anything that could be dangerous. Though in all my years, I've only had one guy get one problem. He got an infection from an intramuscular injection. It was not pretty, but was not disastrous either. So number one is the testosterone Sipinate self-injections. And I have them loaded up in an 18 gauge needle. And then they usually give it in a 25 or 27 gauge needle. And they give it in the subcutaneous fat periumbilically. They compress for 5 minutes. It's very benign. And they get very good absorption subcutaneously. So I much prefer that to them giving IM. I just think it's safer. In terms of dosing, it comes as 200 milligrams per cc. It is a restricted drug. So if they're only using 1 cc a week and you write a prescription to a classic pharmacy, they will give them these 4 very annoying 1 cc bottles. If you are willing to write your prescription in a way that makes it convenient for the patient, where they're taking more than they're actually, it says that they should take more than they're actually given, then they can get a bottle of 10 cc's, which is a multi-use vial, and it's very easy. My classic starting dosage, which is much higher than most people will give, except people in my field all give this, would be 0.7 to 0.9 cc's a week. So that's 140 milligrams to 180 milligrams a week. And that is my starting salvo. And then what I do is I do check their levels a month later. I make sure I encourage them to do it on weekends. I think compliance is better. And then I know that they haven't done it the day before they come to see me. So I'm getting sort of an artificial peak. And then ultimately I follow them every 3 months afterwards. And again, I look for both the levels and symptomatology. There's two sort of groups of men. Some men after the first month come in and they're like, oh my God, I feel amazing. I've never felt this good. This is like the fountain of youth. And I'm like, that's great. You're not going to feel that way forever. You will not be a teenager again. So some people get this amazing semi-euphoric spike, and then they come back down and join the curve. And for most men, that's not the case. And they sort of have a very gradual sort of increase in improvement in symptoms. And again, I'm looking for energy, libido, ability to take off fat and put on muscle. I really, really, really stress that they do exercise with this. A lot of my patients will sort of call it a virtuous cycle, like men with low testosterones. It's hard for them to get motivated to go to the gym. They go to the gym, they're exhausted. They don't put on any muscle. They don't take off any fat, and they take a long time to recover, and they stop going. On the testosterone, there's just dramatic changes in terms of the way they feel and their response to the exercise, which is why I have running arguments with cardiologists who, but we'll get back to side effects in a minute, who are like always telling their patients with low testosterone to lose weight. They hate them being on testosterone. And then I send back their patients and they've lost, 20 pounds of fat, put on muscle, and they're doing cardiovascular exercise, and there's no way they're not living longer. So that is the other option that I use the most in patients are the Testopel, which are bioidentical testosterone pellets that are placed once every 3 months subcutaneously in the fat. We use we use your tush, and I love that because it's bioidentical. It's every 3 months. I don't have to worry about compliance. Again, getting that covered by insurance depends on the two low levels before 10 o'clock and their particular insurance. But I would say 80% of my patients are on one of those two, the subcutaneous injections or the Testopel. So now let's talk about side effects. You can cut me off, Terry, whenever you want, but let me spend 3 minutes on side effects. So the two things that people worry about, there's two side effects that are real, and there's two side effects that people worry about. Let's talk about the real ones. So the first thing that we see is some of the men, especially if they're not using bioidentical testosterone, will become more polycythemic. So there is no question that increasing testosterone levels will increase hematocrits in some men, and not an insignificant number. I've had some people actually who were so anemic, they were on erythropoietin, and then they went on testosterone and stopped their erythropoietin. So that was heaven. So I'm always very happy when my guys come in and they have a low normal hematocrit and hemoglobin, because they're going to feel better as it goes up. I'm not going to have to worry about their levels. And so I'm getting a plus plus. But there are definitely men who become slightly polycythemic. And again, if you talk to enough people, and there's a different definitions, I have never seen a good paper, and I have looked and looked and looked, that really shows any increase in cardiovascular events in hematocrits below 55. I'm not comfortable with a hematocrit of 55, but I haven't seen it. It's more of a theoretical. So what I do with my patients whose hematocrits go up, first of all, the blood banks love me. I have a sheet, and my patients are donating blood on a regular basis. As an aside, if you're trying to get your patients to donate blood, I looked it up. You burn 650 calories when you donate blood, trying to replace all of the sugars and proteins. So it's a great incentive. I think they don't advertise that at the blood banks because I think they're afraid of a lot of anorexic people, like going from bank to bank to bank. But it's a nice 650 calories. So they bank, they donate blood. I have certain men who are not allowed to bank blood, and then I do therapeutic phlebotomies. And of course, obviously, I will bring down the level if we're having a hard time maintaining their hematocrits. The other side effect that we see is, of course, testosterone is converted by aromatase into estradiol. So many of the men, if they go up on their testosterones, will get a higher estradiol. There is no evidence, again, that a higher estradiol is a problem, except that some men get symptomatic. And of course, the main symptom can be either breast tenderness or a little bit of gynecomastia. There's literally almost no men in the world who want gynecomastia. Even very non-vain men do not want gynecomastia. The nice thing is that either we can go down on the testosterone, or we can block very easily the conversion of testosterone to estrogen by an aromatase inhibitor, and the one I use is anastrozole. So there is a decent number of men, I would say 20% of them, who end up on anastrozole if they don't want to come down on the levels of the testosterone. And they do quite nicely on that. And it's a very long-acting medication. So actually, some of them are on 1/2 pill every week. Some of them need it 1 milligram, every day. We do need men to have a certain level of estrogen. If you were asking me an ideal number, I would say 20 to 40. They need it both for libido and, of course, for bone health. So we're not ever trying to get in a man without cancer, estrogen's down to zeros. So those are your two side effects. The side effects that people worry about, which have pretty much been debunked, but are still out there, and I think are still being inculcated in the new generation, are, is it going to increase my chances of prostate cancer? And is it going to increase my chances of having a heart attack or stroke? So I did attach the paper that was the most impressive study looking at the relationship between exogenous testosterone and cardiovascular disease. It came out in JAMA. It got no attention. It's huge. It's from Kaiser. Off the top of my head, it's 24,000 patients with low testosterone. 8,000 of them were treated with testosterone. The other ones did not want to be treated. They looked at all cardiovascular events for 3 years, including, TIAs, strokes, sudden death, need for acute, heart attacks, anything, And interestingly, and not surprisingly to me, the incidence went down by 1/3 in the men who were treated. Very sort of counterintuitively, if you think that there is a link with, if testosterone replacement therapy is going to increase it. The reason I think is sort of obvious. I don't think it has anything to do with the chemical testosterone. I don't think testosterone is at all protective for coronary artery disease. It's just that what happens is the men do a dramatic turnaround in terms of their energy, their exercise, their taking off fat, putting on muscle. Their lipids improve not because the testosterone does that, but because they are exercising and losing weight. So it's fairly dramatic, but yet it's still out there that it will cause heart attacks and strokes. That's still very prevalent a thought. More and more, the fact that it's going to cause prostate cancer has sort of fallen by the wayside. The easiest way to prove that is that at this point, I share a lot of patients with Sloan Kettering in New York who are on surveillance protocols for diagnosed and confirmed low-grade prostate cancer, and we have no problem putting them on testosterone. So these are guys with confirmed low-grade prostate cancer. We do know, of course, that men with metastatic prostate cancer, if we castrate them, we used to do that actually in the old days, we would actually remove the testes. Now, of course, we do it chemically, which is a lot sweeter. And those men, of course, we have to get rid of their testosterone. But there is no evidence that increased testosterone makes either prostate tissue or prostate cancer grow after you've reached a level of 300. So the current theory is that basically you've saturated your receptors on the prostate for testosterone by the time you reach 300. So if you have a guy whose testosterone is 200 and you put them on testosterone, you will see usually a jump in their testosterone, but it will then level out, and you will not see it if you go from 300 to 600 to 900 to 1200 to 1500. You won't see incremental changes. So you sort of use that testosterone as the new normal, the PSA as the new normal after they've been on the testosterone. And so there really is no issue there. So that is the story in my mind. We will not probably do erectile dysfunction, but I would love to answer any questions.
Well, Michael, thank you for that really, really good overview. And I just want to make sure I provide a proper disclosure. You were talking about an endocrinologist. Up until about 5 minutes ago, there was not one on the conference. So now Denise Armelini has joined. And so I just want to make sure you are aware. The rest of the doctors that are here are all internal medicine or family practice.
Got it.
So if you have a question, just raise your hand and I'll call on you and we'll let Michael answer. Uday?
Oh, hi, Michael. Thanks for the great talk. I am an internist and just wanted to, you started with morning levels of blood work, and I think it's still important because we as a check a lot of other things besides testosterone in the morning. So we check the sugars and the A1Cs, and if you're checking FSH, LH, or anything else, prolactin levels, morning blood work is great. So just wanted to give you a feedback that morning blood work, we still love it.
Yeah.
Have to be 10 o'clock because besides testosterone, there's cholesterol and so many other things that we do. So just kind of wanted to comment.
It does not hurt to have morning. Yeah. The interesting thing is, so I have my own lab on site, and it's very hard if which the patients love. First of all, we draw the blood and we can either send it out or do it, but mostly the things that, again, I tell them there's different systems for measuring, triglycerides and glucoses are affected, of course, by fasting, but actually there are systems that can actually measure total cholesterol, which, I mean, we don't have to go through that, is less effective.
No, I know. Yeah. So LDL and stuff, sometimes non-fasting is better than fasting, but I agree with you. Great presentation. I just didn't get your last point. Did you say that you have patients who have been diagnosed with prostate cancer and you still give them testosterone replacement therapy?
Correct. So I share, and that's true. I share a lot of patients with Sloan Kettering, and prostate cancer has fortunately evolved both in our diagnosis and treatment, because we know we've been way over treating men with low-grade prostate cancers. Honestly, if we sectioned the prostates of every man on this conference, a good percentage of us would have foci of low-grade prostate cancer. They actually found that in the poor kids who were killed in Vietnam in their 20s. So what you don't want to do is diagnose a low-grade cancer that's never going to kill anyone and then do aggressive management like radiation and radical prostatectomies. So we find that, there are the surveillance protocols now for low-grade prostate cancer. And yes, because we know that testosterone does not make prostate cancer grow, certainly benign prostate cancer grow, and certainly not more once you've hit 300, then there's no issue having them on testosterone replacement therapy, increasing their testosterone while we're managing them on a surveillance protocol. So to my mind, that's sort of like the ultimate proof that even the very conservative urologic oncologists are very comfortable with a lack of causality between increasing testosterone and and progression of prostate cancer.
I mean, I agree with you. There's never been like testosterone and increased testosterone causing prostate cancer, but honestly, I haven't had anyone who has prostate cancer with the prostate intact and giving them treatment for testosterone. So,
right.
First time I'm hearing you, and
right.
I could understand the 300 and 600. So, were you saying that you keep them at 300 milligrams per deciliter testosterone?
No, what I was saying, so I guess going back to that point, I think, again, it would be unusual. You need experts sort of like Sloan Kettering who are comfortable enough with the surveillance protocol, right? Because a lot of people aren't comfortable with that. You really have to, you can be conservative, in my mind, the more you know, sometimes ironically, and you can be aggressive the more you know, ironically. So what I was saying is that all the evidence biochemically seems to be that the receptors on the prostate for testosterone are saturated at a level of about 300. So you will see some prostate growth and an increase in PSA if you take a man who's significantly below 300 and bring him up to 300 or more. You will see that. You won't see cancer, but you will see a growth in the prostate. But once you reach 300, if you go up higher, you've already saturated your receptors, so you are not going to see any change in PSAs or BPH. After you can go up almost ad infinitum. You don't want to do that for other reasons, but it's not going to affect the prostate because you've saturated your receptors.
Okay, Denise, you had a question? We need to, can you unmute, please?
You're muted.
There, can you hear me?
Yes.
Hi. Sorry I missed the meeting. I'm planning to see it afterwards, but I was in a different meeting. So I'm seeing a couple of younger patients in their 30s with testosterone levels in the 300, which to me that's low, even though the guidelines and the Endocrine Society says less than 250. But
Good for you. Yeah.
So,
yeah, I agree. It's a low number for someone that age.
Right.
Yeah.
For somebody who is 30, 35, having 350, it's low. And so I've been, also diagnosing these patients with sleep apnea, which I treat first before I start testosterone replacement therapy. But I've used a lot of Clomid on these patients because I feel like it just works so nicely. Do you have any experience with Clomid for?
So yes, huge amounts of experience, because I'm doing this for a long time, but also I have lots of men who come in with infertility. And I guess we didn't talk about one of the side effects is we know that exogenous testosterone suppresses FSH and LH. Really the LH is the issue, which means that the testosterone is not made in the testes, which you need in order to have sperm production. So it can shut down sperm production. It's actually the worst of both worlds because it doesn't always shut down sperm production. So you can't use it for contraception, but it does it enough that you can it's going to knock them out. So the Clomid or HCG, so Clomid, just for the non-endocrinologist, is a selective estrogen receptor modulator, but basically, if you think about it as increasing FSH and LH, which then makes the testes make more testosterone. So it also bumps estradiol sort of disproportionately to what the testosterone does. The problem is it's a great drug. It's very easy to take. It's very inexpensive now. It's generic. I actually give it to people every other day so they don't get tachyphylaxis. The problem is that they don't feel, their levels can be raised fairly dramatically with the Clomid. They don't feel as good as if they're on the testosterone. So it does not, and it doesn't make any logical sense. It's just completely consistent across all of my patients. So I can get the exact same level on the testosterone. Again, I cannot tell you why. I just know it's true. And they don't feel nearly as well as when they got that way on the testosterone. Now, the middle one, of course, is HCG. So HCG is given as a subcutaneous injection 3 times a week. Very expensive, has to be refrigerated. And it does not suppress sperm production nearly as much. It suppresses LH, but it's acting as LH, so it doesn't really matter. But the men feel better on the HCG than they do on the Clomid, but they don't feel as good on the HCG as they do on the testosterone. So the Clomid is a great placeholder for younger men who want to conceive. But if they're finished having children, for sure, then I put them on testosterone, even if they're younger. If they're worried about testicular atrophy, which is what you get with the exogenous testosterone, then I will sometimes give them a touch of Clomid or HCG. But I applaud you because I find I was ragging on endocrinologists earlier because in general, I find you guys very, 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 very absurdly conservative with testosterone. And in fact, I have rarely heard an endocrinologist say what you just did, which is like that would ever treat anyone if it's over 300. So I applaud you. And if you were 20 years older, you wouldn't be saying it because no one in that generation will do it. Yeah.
So I see that the younger endocrinologist generations acknowledge to me that they are really not doing a lot of this and they didn't get a lot of training on it and they're more open to getting support. So that's one thing that I'm seeing in a lot of, even the ones that are, coming out of all of our bigger centers, people that have finished at Sinai, people that have finished at, NYU and Cornell, the ones that I'm talking to, they acknowledge it.
Right. What I'm finding, which is lovely, is that they will call me and they will say, I know you're right, but I am taught this way. I know they need a higher level. I cannot get myself to write it. Will you manage their testosterones? And I appreciate that. That's fine. You can put me right into the lion's den because I have no problem doing it. So I applaud them for sort of saying, I'm not comfortable with this, but I don't feel I'm managing it well. Yeah, no, it's an interesting flaw. And I think that, also testosterone in women is a whole nother topic. I am very pro. And, the way we're treating women and menopausal women just literally we have a women's center too, drives me literally insane. I think we are so massively under-treating women for fears of things that are very unlikely to happen and really decreasing their quality of life, So that's its own sort of topic.
Thanks, Michael, and thanks, Denise. Other questions from the audience?
Hey,
Michael,
Mike,
did you?
I had a quick question. You're using anti-estrogen therapy to boost up the testosterone. So we're basically talking about the steroid hormone pathway, starting from cholesterol, going into all different directions. Do you ever use DHEA?
So DHEA is very interesting. Yeah, I like DHEA, unfortunately, has very little data connected to it. Again, with any supplement, you have to be really careful. So I've sort of done the research, and I actually, if I'm going to give them DHEA, it's very inexpensive. I literally hand them a brand that I know is good, which I happen to use Puritan Pride. I don't charge them for it because we're talking about $3, So it's very interesting. I do check DHEA levels, and it does make me uncomfortable if they're super, super low, right? If you get a guy who's in this, in the double digits as opposed to the triple digits, that's sort of, and it is a precursor, of course, for so many hormones. And there's some data that shows that people with good DHEA levels actually live longer, and there's some data that shows it makes no difference. So I actually, it's one of the only, I would call it a supplement that I actually do use. And it's at least working biochemically because they take it, they don't have any other side effects, and they get much better DHEA levels. So I usually will treat them if they're very low. If they're marginally low, then I don't bother because again, I'm sort of a maximalist. I like really low lipids. I like really high testosterones. I think we undertreat a lot of things. But with the DHEA, we just don't have the data. We actually find it the most useful, and we actually tried to publish a paper. It hasn't been published. I'm not sure why. With premenopausal women with low libido, it's actually very useful, interestingly.
Yeah, because it turns into testosterone. Yeah.
Yes, that may be. But the interesting thing is,
and that's why we give topical testosterone to menopausal women to increase their libido. So when you do
yes,
DHEA,
I think they need it.
Testosterone.
100%. Yes.
Thanks.
Michael, we have about 15 minutes left. I know some of the audience was probably interested in the other topic, the ED, and some of the people who are going to listen on, afterwards or watch afterwards. Do you want to take 10 minutes to talk about that?
Let me start with the ED. One of my second true love, or my first true love. So I think the principle with, if you look on my website, my wife was in marketing when we first met, and she said, well, how good are you at getting guys erections? And it's like, if they have a penis, I can get them an erection. And she was like, well, that's strong. And and I really do tell the patients that. So you have to assume that every man who wants an erection should be able to get one. And obviously you start with the least invasive and you go up in terms of treatment. Why I can say that every man who has a penis can get an erection, I don't do the prostheses anymore, but I think for the right patient, they're amazing. The patients love them. They are, fabulous. And if you get a 64-year-old diabetic who's not responding in my hands to any of the other conservative treatments, they should have a prosthesis, and they do beautifully, and they're the happiest men you will ever see. But let's back up. So, again, I won't even go through an etiology workup. Let's just go through treatment because I think that's what affects you guys the most. So let's talk about first the PDE5 inhibitors. So I think you guys probably spend more time with your patients than the average internist, but most of the time, what happens is the guys come in with erection issues, and their internist writes them for the lowest dose of Viagra, right? So Viagra, the max dose is 100 milligrams, and they don't give them any specialized directions. So Viagra, sildenafil, it's now generic, thank God, is the most powerful one, but it is the least convenient because it can't be taken on a full stomach. So, and it really doesn't work for the most part if the men are not if they haven't been fasting. So I always tell the men it's great for early morning sex if you don't have children, because you wake up, you take it, you go back to sleep, and then you're ready. But it is the least convenient and does have the most side effects, and it does not work if they don't have an empty stomach. So it's really important that I go through the pharmacokinetics with them because it peaks at about an hour after you take it. If you take it with food or you try to have sex 8 hours after you take it, you're not going to get any effect. Backing up for a second, this is, again, I am a maximalist. When you write the prescriptions for the PDE5 inhibitors, I would encourage you, because they are a shockingly safe group of medications, especially if your patient, you can't use it if your patients are on nitrates, go to the max and work backwards. I know it's very counterintuitive in almost every field of medicine, but not in the PDE5 inhibitors, because you want to break through. Once you start having erection issues, then there's an anxiety component that exacerbates it. And you give the man a low dose of Viagra. They don't know how to take it correctly. They fail. And it took them 2 years to get up the courage to ask you for it in the first place. And now they think that they're the only men who that's not working for either. So I give everyone the max dose. And they say, well, when can I come down? It's like when it's obvious that you can come down, you can come down. You know, if your partner is standing naked in front of you and you get this great erection, well, then you may not need that medicine this time, you know, but we're not trying to get rid of it. There's no tachyphylaxis. There's no psychological dependence. I really would encourage you to start with the max dose. So the max dose of the Viagra is 100 milligrams. And again, it cannot be taken with food. It is one of the less popular, even though it's the strongest, because the food issue, and it does seem to give the most side effects. Headaches, blurred vision, blued vision, heartburn, facial flushing. Those are your main ones. My favorite one by far is tadalafil, which is Cialis. Again, the dosing of Cialis for as needed PRN is 20 milligrams is your max dose. Please start with the max dose. They can always work backwards. Worst comes to worst, they get a splitting headache and they know that they have to go down on the dose. Or a lot of men like the erections and they take it with some Motrin, and that works too. And so you start at the max dose. Again, it's pharmacokinetics. I actually have a chart that I give my patients. It peaks at 2 to 4 hours, very variable. Its T1 half is 18 hours. So they have a very long window. A lot of the men who, if they go on the max dose, will find that they wake up the next morning with a rigid erection. Men, we all love our penises and we all love them erect as often as possible, except for when we're 14. And men love their morning erections. They are very happy to see those. So they're not useful most of the time, but it's psychologically, it's very good. So that's the Cialis. Now, again, for the guys who have modest erectile dysfunction, we can give them the 5 milligrams daily. And for some men, that is adequate. It is very hard to overdose on a PDE5 inhibitor. So I have no problem with them doing the 5 milligrams a day, especially if they have lower urinary tract symptoms, and then taking another 20 milligrams prior to sex. There's 2 other ones. I never use Levitra. It just doesn't have a place. But there is a newer one called Stendra. The generic is Avanafil. It's a great drug. It's the weakest of the bunch, but it kicks in within 15 to 30 minutes. So for spontaneity, it's heaven. It is still branded, so it's expensive. I can't figure out how they do that, but we have found at least one compounding pharmacy that will make a troche. Again, we don't profit from it. They do directly with the compounding pharmacy. So, and those are about $2 each. So it's very nice to use those. I mean, I'm 61, that's my drug of choice. I like that drug. It's just very few side effects, kicks in very quickly, out of your system quickly, but it is the weakest. So at a certain point, it's not going to work for most of us. The other key thing with the PDE5 inhibitors is to make sure that you get them cheaply. So for example, locally, we have a pharmacy called Baybridge Pharmacy or Sparta, and they have it at 50 cents a pill, and they'll deliver it for the Viagra and the Cialis. Everyone, I'm sure you guys all know GoodRx.com, and at Stop and Shop, which is a local one for us, they're even cheaper. They're like 20 cents a pill. So with a coupon for self-pay. So, you know, it used to be when they first came out, Viagra was $8 and the patients were going insane. And then I thought that as they got new medications, it would go down in price, but they went up in price. At one point, the Cialis were $60 a pill. So people really did not want to waste them. Okay, so that's the PDE5 inhibitors. The other thing is that they don't work for everyone. They only work for about 85% of men, and they only work if they're taking them correctly. I love, love, love the penile injections. I've started my practice in 1994. Viagra came out in 1998, on my anniversary. And before that, everyone who came in virtually was on the intracavernosal injections. And I still have conservatively 1,000 patients on them, and over the years, more. The idea is very unappealing to people, but the way I do it is I will have them use an auto injector, and they put the needle in. It's a reusable auto injector. They literally feel like they've been flicked with a rubber band, and they get amazing erections. And I remind them that most of the porn stars are using that, which is why every man in the world feels like they're terrible in bed and why their penises are small, because now they've watched a lot of porn. It gives really, for most men, it gives them amazing erections that are, in order to have sex, you have to both get and maintain the erection. And so they're extraordinary, and they work for the vast majority of men. Again, we have that small group of men that it doesn't work for because they have too much occlusive dysfunction. You have to get the blood in, you have to hold onto it. If you can't hold onto it, it doesn't matter how much we pour in. And if we can't activate your trapping mechanism, it's not going to work. And those are the men who need the prostheses. But I would say that I get 95% of the men up and running with the injections. They love them. And the rest, if I can't get them up and running on the injections, then they really do need a prosthesis. But they need to be instructed on how to do it. It takes 3 visits for me to really teach them to do it correctly. I do not let them loose with the auto injector and the medication until they have proven to me that they can do it in the office and that it's working, or that I'm getting close to it working. And the goal is a rigid erection that lasts as long as they want without being crazy, and then goes down. As an aside, not that you want long, erections that last 4 hours. That is not a panic situation. You really don't get permanent damage, ischemia to the penis, until you've had a real priapism for 24 hours. So we use the 4 hours as a signal that we're getting into trouble land, but we don't go insane over a 4-hour erection. And then if a man is consistently getting 4-hour erections from the injections, of course, then we cut down on the dosage. And some of the men will, a lot of the men, this is psychological. I've had teenagers who need the highest dose of medication, and that where there's nothing physically wrong, I've proven it. And then over time, as their confidence comes up, they've just sort of weaned themselves off. The other things that are sort of interesting and sort of out there, which have moderate data in it. So I've actually begun offering them, though it's not the mainstay of my practice. There is low intensity shockwave therapy, which if you use the right device and the right protocol is pretty effective, and the data is pretty good. And I finally started offering, and just in the last few months, because there was a great paper that came out from Greece that was a double-blinded placebo-controlled study for PRP in the penis. But it's only indicated for people with very mild erectile dysfunction. And it was the difference between placebo and the actual treated was significant. But again, there's always a placebo effect in anything in erectile dysfunction. But so the treated patients, 70% of them improved significantly, in the non-treated 30. So that was a pretty big difference. But the patients really need to be selected carefully. It would have to be people with modest erection issues who are either trying to graduate from the injections to the pills or from the pills to nothing. So again, sort of cutting edge in erectile dysfunction medicine. You can be a shyster and you can get people to do anything. People are really desperate sometimes. So you really have to sort of walk the line, and my father was a physician. He always said, don't be the first one to offer something and don't be the last. So I've sort of very modestly integrated those into the practice by giving patients, low expectations, because it really only works in certain situations. So that's ED in a nutshell.
Very good. You did a great job with that. We have time for probably a question or two. Anybody have a question on that topic for Michael? Bradley, go ahead.
Michael, with the Cialis that people are doing, it's the Dalafil 5 milligrams daily. I see a lot of it for BPH as well, and for urine flow. At least I see a lot of the urologists using it. Do you know anything about how what's going on there and how the mechanism is?
I know that it works. The data shows that it works. They have no idea of the mechanism. It's just that it actually is at this point FDA approved for men who have lower urinary tract symptoms and ED, which was important, especially when it was branded. We actually could get that approved for the men. I happen to love the 5 milligram daily dosage for lower urinary tract symptoms. I am fortunately or unfortunately almost becoming a national expert, which I really, on chronic pelvic pain syndrome. And I am a great believer that the three-legged stool. For that is pelvic floor therapy, daily Cialis, and an anti-anxiety medication. So I use a lot of daily Cialis at this point. And it really, I think, again, my area is not BPH and lower urinary tract symptoms, but my patients know me very well. And if they have modest symptoms, I have a very low threshold for putting them on 5 milligrams of tadalafil daily. They love the extra erections. The side effects go away after a week. And of course, the alpha blockers, which are the next level, can give retrograde ejaculation and postural hypotension. So I love the daily tadalafil. You're rarely going to get into trouble with it.
Okay, Uday, do you have a question?
Yeah. So Trimax is used a lot, combination compounded injections for penile. Do you guys use that at all?
Yeah, the Bimix, yes. So the penile injections, the 3 ingredients can be prostaglandin E1, papaverine, and phentolamine. So Bimix is papaverine and phentolamine. Prostaglandin E1 can be used by itself, and then Trimix is when you put all those 3 together. There are some people who use quad mix. They add atropine. Like there's a bunch of different combinations. I've sort of stuck to what I was trained with, and I haven't been impressed with the data for the other things. And they have more side effects, so I stick to those. Yeah. Just to parse the okay.
Oh, go ahead.
The PGE1 is available by prescription, though most plans don't pay for it, as brand names of Caverject and Edex. So if I can get away with that drug, I will write it, but then I teach them how to use it with an auto injector. The disadvantage is that if it's pre-mixed, it has to be refrigerated. And in 20% of the men, the PGE1 causes aching. The papaverine and phentolamine never cause aching, which is very nice.
So do you start at 200 milligram dose somewhere there?
The PGE1 goes up to 40 micrograms. And I sort of get away, when I'm doing I like an evaluation that lets men know what's going on. So depending on their baseline erections, when I'm doing their initial ultrasound, I will give them 40 micrograms of PGE1. The other advantage of the PGE1 is that it's broken down in the penis. So your chances of getting a priapism are minuscule. So I always start with that, warning the patients that it can cause aching and letting them know that the other ones never do, so that they're trusting if they do get the aching.
Great, thank you.
Michael, thank you.
My pleasure.
Great talk. Very, very interesting. Thank you all, the rest of you who've taken time out of your very busy schedules in your evening to join us. And for those of you who are going to be listening to this by recording, if you need to have or need questions answered, or you have interest in connecting with Michael, I'm sure he'll be available. I'll have his email address on the recording. So with that, I will wish you all good night. Bradley, thank you for introducing us to Michael. It's great to have our clients, recommending other doctors who could do these conferences. So if any of you have people who have areas of expertise, we'd love to be able to share that with our network. So with that, I'll say good evening and look forward to seeing you next time.
Good night all. Thank you.
Bye.
Thank you.
Thank you.
Thanks, Michael. Take care,
Bye.
everybody.